All right, well, we can get started. My name is Jennifer Beckman. I'm a nurse practitioner with the MCS Consult Service here. I've been here a little over a year. Thanks to Carrie for letting me talk today. I'm going to talk about all things advanced heart failure and MCS. I'm going to go through short-term devices and then also a little bit about durable devices as well, just to get the continuum of care and what the MCS Consult Service does. So here, the Consult Service takes care of advanced heart failure patients who are close to getting a durable device or needing a short-term device, and we'll go through all of that in a little bit. We also take care of immediate post-transplant patients and transplant patients that come back to the hospital for anything other than a cardiac issue, so like DVTs, things like that, pneumonia, whatnot. And then we also get consulted on any heart failure patient that another primary team needs help managing. So first of all, welcome to UW. I think it's a great place to be, so we're excited you're here with us. To jump right in, I wanted to review the classification of heart failure. This probably is a big review for most of you, but it's really important when looking at the actual stages and functional classes for our patients, and you'll see a lot of this lingo and jargon in our notes every day, so it's just good to review. Most of the patients that we see on the consult service who are in need of a short-term or durable device or transplant are stage D, so that's the bottom left. That's refractory heart failure needing an intervention such like a short-term device or inotropy, things like that. And then the functional class, we're mostly between functional class 3 and 4, so minimal exertion or symptomatic at rest. Something else to keep in mind is your stages are typically static and progressive, so they continue on, and it's a progressive worsening of their stage, heart failure stage. The classes can be dynamic, so patients can be 3 and then they can develop 4, and if you treat them and they get less symptomatic, they can be deemed functional class 3 again. And you'll see that with some of our durable support patients who we put a VAD in and they feel much better and they functionally can actually move around a lot more, and most of the time we can get them back to a functional class 2 at minimum. So something else to keep in mind here is that our patients who we see, again, are stage D and typically stage 4. So symptomatic at rest, just to think about that a little bit more, is really they're not doing anything. As a mentor once quipped, you can't do less than just lie there. So these are the patients who are they're talking to you in bed and they're short of breath, they're dyspneic, they're underperfused, those types of things. So I really like this quick heart failure assessment that Dr. Lynn Stevenson wrote out, and it discusses being congested and having low perfusion. So on the left side you see low perfusion at rest, and on the top congested at rest, and this is a really fast way that you can go in, touch your patient, examine them, look at their labs, and have, within 5 minutes you can understand how sick they are. So low perfusion at rest, what does that really mean? So are they cold? And a lot of people, when they hear the term cold and wet, I'm sure you've all heard that, cold and wet, warm and wet, maybe not, but a lot of heart failure people use that. It doesn't necessarily just mean are their extremities cold, are they so low perfused that their extremities are cold. You can actually look at perfusion, so blood pressure, are they hypotensive, is their pulse pressure really narrow, things like that can let you know if they're low perfusion while just sitting there at rest. Congested at rest, does that mean that they have an elevated JVP? Do they have an S3? Are they edematous? All of those sorts of things. And what they found out was that your bottom right quadrant, your cold and wet, are the most sick and need our attention the fastest. So while functional classes and heart failure stages are great, the advanced heart failure world felt it was even more important to get another stratification scheme to figure out when the best time to intervene on an advanced heart failure patient is based on survival. So they developed something called INTERMACS profile stratification, and these are numbers you're going to see in our notes again. They're based on, again, survival, and there's 7 of them, as you can see. They range, it's all with the between a class 3B and 4 patient. So if you think of the classes, this kind of divvies up that last class, the sickest heart failure patient that we're going to see. And it goes all the way from class 3B, so mostly functionally symptomatic with exertion, all the way down to multi-system organ failure in a patient that's dying. So as you can see, the INTERMACS level correlates in the middle to different survival and if there's benefit to doing a device. So in the first 3, 5 to 7, those are heart failure patients who are in the house. They're not really functioning a lot, but they're getting by on their own. And those survival patients are months to years. And VAD typically isn't proven to be a great benefit. We'll talk about this a little bit more, but you want to make sure you intervene with circulatory support at the optimum time, and we'll talk more about that in a little bit. Our INTERMACS level 3 to 4, their survival is only weeks to months, and this is our patient who are on an inotrope. They're stable, however, they're the ones who come back into the hospital frequently. And VAD for these patients is completely ideal. It's where we want to see them, what kind of therapy we most likely tend to go for.
Are they always on an inotrope?
Not always.
Oh.
Right.
So really the threshold for inotropes is INTERMACS profile 3. 3, 2, and 1 are on inotropes or intermediate inotropes. I think the simplest way to differentiate the two is to say INTERMACS profile 3, like Jennifer said, means stable on an inotrope. That means they're not having accelerating symptoms. We're not having to escalate diuretic therapy on the same dose of inotropic support, which is another thing that things are not stable. And they're also not showing any sign of end organ compromise. So mixed venous O2 is at greater than 65%, and no evidence of cardiorenal syndrome, congestive hepatinopathy, anything like that. If you have to increase the dose of the inotrope, escalate diuretics, if they're symptomatically deteriorating or their end organs are going down, then they become 2 and ultimately 1, which is what we're trying to prevent.
Mm-hmm. So, exactly. So we like to implant patients and intervene around 3 is like the Goldilocks profile, but unfortunately not all of our patients come in that shape. So if they do come in the crash and burn profile 1, we try to stabilize them from all of the points that Dr. Marr said from an end organ standpoint, make sure that they can make it through a surgery for a durable device before we do that. So this is another way to look at it. It's a little bit busy, but focus on the arrow and the shaded area. And this is a way that you can look at a patient's clinical course, their quality of life, how intense their care needs to become, and when we really need to intervene with advanced heart failure therapies. So typically it's when decompensations start happening, when patients start getting re-hospitalized, you have to back off on their neurohormonal medications like their ACE inhibitors and beta blockers because their blood pressure can't tolerate it and essentially their pump is failing. And that's when we start to consider MCS therapy or have already considered MCS therapy and we're ready to intervene. So going along with the topic of cold and wet, this is another way to look at a decompensating patient, and it's very typical that this is how they present. So cardiogenic shock is both a diastolic and a systolic component. Diastolic, you're going to see more of the wet features like we talked about, where patients become edematous, they get pulmonary congestion, essentially everything leading to more hypoxemia. And on the systolic side, this is where you're going to become a low perfusion state mostly, where your cardiac output and stroke volume are going to decrease. your perfusion is going to go down, more hypotensive, narrow pulse pressure, etc., and eventually leading to more ischemia and then more myocardial dysfunction than they have. So, to get even more pessimistic, we know that patients have poor survival on medical therapy. So, what we see in this graph is showing survival of less than 12 months, and this is based on the fact that we know patients who require an inotropic support like milrinone or dobutamine, if we cannot get them off of that with a stable mixed venous and organ function, not having to escalate diuretics like Dr. Mara was saying, they have a 90% mortality at 1 year, which is pretty staggering.
These are class 4D patients.
Mm-hmm. Yeah. So we also know that when, like I mentioned a little bit ago, when you have to start peeling back on someone's blood pressure meds and they're not able to tolerate those blood pressure meds anymore, that's a huge sign that they're spiraling down and that we need to think about something else. So one of our tools in our toolbox, which we use a lot here, is a right heart catheterization in a swan. It's very quick and easy, and it gives us a ton of information. So what this graph shows is the probability of cardiac death based on a cardiac index. So you can see where the curve starts coming down, and it's between cardiac index, well, it's less than 2, your probability of death increases dramatically. So that's anyone that comes in with a cardiac index 2 or less, which is frequent. And it's a really quick, easy way, aside from all the other information that a right heart cath can give you, to know how sick your patient is and how fast we need to escalate therapy. So what can we do with all of these really sick patients? So we have short-term mechanical support and we have durable mechanical support, and we'll go through short-term first. So we have a lot of different tools here at UW to help our patients who are in cardiogenic shock and having difficulties maintaining perfusion on their own. So I'll go through a few of them. We have a myriad of them, like I said here, and the important thing to remember is that there is an MCS consult service, and it's our job to know all about these. So never feel alone. I have to give a plug for our awesome nursing staff too, especially in the ICU. They're amazing at managing these pumps, so you have a lot of resources around you when taking care of these patients. So when do we look to implant a short-term device? So we've been talking a lot about cardiogenic shock. If patients need a bridge to another therapy, so they come in, they're really sick, in shock, we know that they're probably needing a durable device, probably a candidate. We can use a short-term device to stabilize them to make sure they are a good candidate for a durable. And then also we can support patients that are high risk for different procedures, so high risk PCIs if their EF is marginal, CTOs, we've done it for valve replacements, other emergent conditions. I didn't put this up there, but VT storm, something that you need quick to offload the left ventricle, you can place one of these devices in pretty quickly. And what's our goal? So our goal for short-term devices are to reverse the shock. By doing that, we give more perfusion essentially everywhere in the body. So we allow for the patient to be more adequately diuresed with less high doses of diuretics. We increase their renal perfusion, again allowing for more diuresis. We can reverse their congestive hepatopathy, make sure their liver is improving. And most importantly, we can improve their cerebral perfusion, so we can get good adequate perfusion to their brain. So essentially perfuse everything and take over for the failing heart. So one of the things that we use is a balloon pump. Are you guys familiar or taken care of patients with balloon pumps before? No, not too much. So a balloon pump is pretty much what it sounds like. It's a balloon that gets inserted into the aorta, and it is a plastic tubing that gets inflated. I think it's with nitric oxide.
Helium.
Helium, thank you, not nitric oxide. That didn't sound right. And it inflates immediately after the aortic valve closes, so at the dicrotic notch, and it deflates immediately before the aortic valve opens, and it does so to reduce your end diastolic and systolic pressure. And it does this, there's a couple different settings that you can set the device to. It can inflate and deflate with each cardiac cycle, or every other, or every third beat. The important thing to know about this is it only provides about 1 to 1.5 liters of supplemental flow. If you think about having a patient with an EF of 10%, 4%, 15%, that's maybe not going to be enough for them. That's something that we follow, and we help decide which device is best, but just know that it's not a lot of extra flow. It's contraindicated in patients with AI, also if you're really tachycardic or in an arrhythmia, because the inflation-deflation is triggered off of the EKG. If they're in a funky rhythm, it's not going to work appropriately. And again, it just augments flow. It doesn't pull any blood from the left ventricle. It doesn't decompress the ventricle at all. It just augments. Then we have the Abiomed devices, and we have a Swiss Army knife of them available here. And I'll start at the littlest one is the 2.5, and this gives flow up to 2.5. This is very comparable to how much flow a balloon pump can give, so it's not quite used as often as the other ones are here. The next step up from that is a CP that gives you a little bit more flow. And then the one that we use a lot is the 5.0, which can give up to 5 liters of flow. So what do these devices do? So these are inserted where their little pigtails are through into the left ventricle, and there's a little blood inlet area right here where blood comes through, and it's in a little impeller that spins, and it helps, and then the blood comes back out here, back out into the ascending aorta. So it's bypassing the left ventricle and helping to unload the ventricle. Does that make sense? Where it's sitting, can you visualize it? So the 5.0 is, like I said, we use a lot. All of these can be placed in through the groin, through groin access. The 5.0, however, can be placed through an axillary cut down, and patients can actually get up and walk around with the device. The one at the bottom is the RP, and this is designed, you can see the shape is different than the other three, and it's designed to go on the right side for right-sided support. Questions about the Impella?
The ones that the
That's a lot of
CC will
information.
see is the 2.5 and the CP.
And likely ERP.
I hope so, but for now, not.
Have we seen an RP?
We've not.
We came very close last
yeah,
week.
I don't think we've put one in that though.
And CP stands for?
CP stands for, I don't know.
It's Abiomed lingo for
That's it.
more than 2.5, less than 5.
Okay, alright.
Not
We
requiring
could
a
make
cut
up
down.
something, but I don't know if it'd be right. Any other questions about those? Another device from a different company by the name of Thoratec is the Centrimag. And this device is mechanically levitated impeller. So the impeller sits between two magnets and is able to spin. And this we can use for both left-sided support, right-sided support, or both. And you can actually splice in an oxygenator and have an ECMO circuit if you need that as well. So it's kind of a good device if you're not sure how much support you're going to need. This can be placed emergently at the bedside. It's a good device to transport patients on. It can hook up to like all of the choppers and stuff, and also in the ambulance there's they made it really easy for them to hook on to pretty much any transport device that we have. And it can give you lots of flow. It can give you up to 10 liters of flow. So this is kind of stepping it up another notch if you need more support. So we talked a little bit about the INTERMACS profiles and when to intervene with short-term support. And it's important for any intervention to be done at the right time, where you have the maximal benefit from doing something, because sticking these VADs in is a big deal, even though it's done a lot. It's a big intervention, and we need to know where we're going with it, both for our patients and both to manage them. So we want to make sure that we aren't intervening when the patient is doing too well, and we're not intervening when they're too sick. So if someone, what does it mean for someone to be too sick? So for our patient population, to put in a durable long-term device, if their end organ function is not in the game, if we're not sure if their brain has lacked perfusion for too long and they have an anoxic injury that they're not going to recover from, those are all things we need to consider before going towards these durable devices. So our durable devices are devices that can be implanted for a few different reasons, and we'll get to that in just a moment. But I wanted to show you pictures of the current devices that we surgically implant here. And these devices all have inflow cannulas and outflow grafts. So the inflow cannula sits in the, generally the apex of the left ventricle. The outflow graft is attached to the ascending aorta. Each device has an electrical cable that comes through the patient's abdomen and hooks up to external components like this. And we can see all their parameters and change their speed and do all sorts of things for them in the hospital or in the clinic. So we can implant these for a few different reasons, and I put the biggest three up here. These are different than the short-term devices. So short-term devices we typically will keep in place up to, it's like hours to weeks. And the durable devices are implanted for years, sometimes for as long as the patient is alive. So we can implant, and these three reasons you will also see in our notes, these terminology. So BTT stands for bridge to transplant, and this is to bridge a patient to getting a heart transplant. And destination therapy is when a patient is not a transplant candidate or chooses not to be listed for transplant for whatever reason that is, and they have an understanding of wanting to be alive and wanting a durable device, and they understand that they will have the device until they die. So it's a destination, they will have it forever. And then BTR is bridge to recovery. This is mostly used with our short-term devices. Sometimes we can recover patients that have a durable device. There's a few different etiologies where that is more common. An example is alcoholic-mediated cardiomyopathy. If patients stop drinking alcohol, sometimes they recover their heart function. We can either take the VAD out or we don't need the support of the VAD anymore. Big thing to mention is that there's a 40% crossover between each strategy. So patients are static, and they will let us, they're going to change what they do for numerous reasons. So some patients, they want a transplant, and they feel so well with their VAD that they don't want to go towards a transplant anymore. They don't want to undertake another surgery, or they're doing well, and they just choose to forego that at the time. Other patients, if they are implanted as destination therapy, say because they are obese and we can't transplant them safely, they lose a ton of weight, they can cross over and be bridged to transplant at that point and be listed for transplant. So there's a lot of different crossover between strategies that we see.
I think,
Yeah.
just back to that whole BTT, DT, there used to be a bridge to a valve, which
Mhm.
was where what we call people who are smokers or who are obese, we call them DTs now. But really, there are a fair number of people within the DT world who potentially will become bridge to
Yes.
transplants.
Yes.
And so I think it's important to remember not to treat any one strategy differently,
That is a great point.
like with blood products and things like
Yes.
this, because of the high crossover,
Mhm.
especially toward the transplant side.
Yes.
Yeah.
Thank you for making that point. Yeah, we don't mitigate or change our strategy with our patients if they're going to transplant or if they're gonna have the VAD forever. They're treated exactly the same. We, everything is the same with them. We don't differentiate at all.
Just to add what Jennifer has up there and what Carrie alluded to. So this is national data. 40% of the time in the INTERMACS registry, there's crossover. If you ask the multidisciplinary team to say, is this patient ultimately going to be destination therapy or bridge to transplant? So we are asked to make that decision a priori for regulatory and fiscal purposes, but 40% crossover means it's almost as poor as flipping a coin. They will declare results either way. There are some things that are non-modifiable reasons for destination therapy. Say if they have an age limitation, that's not going to change. But other things are very dynamic and they may. So Gary and Jennifer made the excellent point. They should be treated democratically because you don't know what bucket they'll ultimately end up in.
Thank you. So I wanted to go over some basic VAD physiology for you, and this typically goes for all of our short-term devices as well. So the VAD is set to a continuous speed, and it's a continuous flow device. You can think of it, how I simplify it is thinking about a garden hose and turning your hose on at home, and you have continuous flow through that hose. It's kind of what we're looking at. A little bit more complicated than that, but they don't have typically a native pulse. So our patients are not going to necessarily have a pulse when you go to feel for it. They can in certain circumstances. If they're really hypertensive, they can have a pulse. If they have a lot of native contractility or if their heart function recovered a little bit, you're going to see native aortic valve ejection, so you'll feel a pulse during that time. If they're really hypervolemic, really volume overloaded, also sometimes you can feel a pulse. But typically if they're managed well and they're euvolemic, etc., you should not feel a physical pulse. There's no intrinsic afferent-efferent connection, and our VADs are very preload and afterload sensitive. And this is it's a delicate balance between making sure a patient is euvolemic and their blood pressure is well managed and their VAD speed is set as such. And we go, the MCS and the CT surgery team go to great lengths to set speeds based on how their patients look at the time and before they go home and when they come back into the clinic. So it's always kind of a moving point depending on where the patient is and during their recovery especially. When you increase an LVAD speed, you increase the RV preload. You can grasp your mind around that concept. So whatever we do on the left side will make a difference on the right side. I'll get to some complications later, but early on there was a lot of RV failure when providers were putting in VADs because they thought more speed the better. This patient didn't have perfusion for however many years, their EF was really low. Let's crank up the VAD speed to give them lots of renal perfusion and perfusion to their gut, etc. And they found out that if the RV was a little sluggish to recover, that they could really run into issues with RV failure. So there's lots of things to keep into consideration, but those are some of the basic thoughts. So again, our speed is set, and this is a waveform for one of our VADs, and it's just, we are able to see it on a bedside console, which is pretty neat. And you can see different changes, rotational changes on the waveform when different things happen to the patient. So this is kind of our normal area, which is what we see. And then if things happen, we can get different signs and symptoms, and we can see actually on their bedside console that their VAD is not functioning appropriately. So things that we take into consideration again are volume status. You also get into different specifics with inflow cannula positioning and things like that. to make sure that we're optimizing the patient as best as possible. One of the ways that we do that, and also with our short-term devices, is making sure that things look copacetic on echo. And one of the things we can do with our durable devices, and also similarly to when we are managing a short-term device over a long period of time, is we do echoes, and we can see different dimensions during the echo to help us with our management. So we look at the left ventricle and the right ventricle, and see if the left ventricle has recovered any contractility. And we also look at the septal positioning. So more so with our durable devices, Goldilocks for us is having good septal positioning in between the right and left ventricle. The aortic valve opening, we like it to open every few beats so that the aortic valve doesn't fuse for a number of different reasons. And then that will help us find our ideal VAD speed based, again, on their volume status and their blood pressure. For you guys, though, managing your like the Impellas and things like that, once we are trying to wean the patient, it's typically done via echo as well. And what we do is we look at the left ventricle and how it's functioning, see if it's improved its function at all. We make sure the RV is looking okay. And then typically when we're standing there with echo, we can turn down the VAD support and then see what happens. We can see if the left ventricle dilates, we can see if the CVP rises, or if the PA pressures are going way up, and we can do that right at the bedside. It's a quick assessment that we can do to make sure that we're safely supporting the patient. This is more, again, kind of what I just went over. So for our ramp echoes, we want to make sure patients' maps are in good control, that their volume status is euvolemic as close to possible. We look at, again, the aortic valve opening, and would like intermittent aortic valve opening when we can have that.
Can you just go back for 1 second? I'm
Sure.
sorry to interrupt. Just want to really drive this point home. You have to make sure that the blood pressure is controlled and that they are therapeutically anticoagulated by whatever measurement you use to define that before you manipulate the device. And that doesn't matter if it's a balloon pump, an Impella, ECMO, a durable VAD, because they're all high shear devices. They're all very thrombogenic. So if they're PTT or ACT subtherapeutic, then you're essentially predisposing the patients to potentially devastating neurologic complications. So just make sure that before you entertain and embark on any kind of weaning attempts, you have those data available to you.
And we'll be there for those weaning attempts too. So we talked a little bit about RV failure before. It's the right ventricle is really what a lot of people forget about when patients have end-stage heart failure. We can do a lot of things to the left ventricle, but the RV is more limited and it's not as forgiving as the left ventricle. So what we do to help it work correctly and as best as possible is make sure they're euvolemic as much as possible. And again, that goes back to using short-term devices to help patients get euvolemic with more perfusion rather than slugging them with more diuretics when that's not good for their kidneys. We make sure that their VAD is set correctly. So the VAD speed could be set way too high, it could be set way too low. How we figure that out, again, is looking at the bigger picture, and it's also using echo a lot of the times to see if our speed is not appropriately set. The other things we do are we get right heart caths very frequently. We want to see what our PA pressures are. Typically in the unit, these patients will have a swan in anyway, so we'll be able to see that on the fly. And then we use phosphodiesterase inhibitors quite frequently. The data is not really out there, but we use it a lot, and it seems to bring down our PA pressures very nicely. Why we worry so much about our high PA pressures, besides the obvious reasons, is if these patients are going to transplant. Susan might mention this, but you can't transplant someone with a super high pulmonary pressure because the right ventricle of the new heart isn't used to pumping against those high pressures, and it can fail. So a lot of our advanced heart failure patients who have really high pulmonary pressures, if they have a durable device in, typically within a couple months they'll decrease, just essentially because the left ventricle is offloaded and you don't have the same hemodynamics as you would if it's just a normal advanced heart failure patient with an EF of 10%. So, but we also use phosphodiesterase inhibitors, and that's medications like Revatio, sildenafil, those types of meds. Other complications we can get, Dr. Marr mentioned these pumps are, they can give us lots of hemolysis, and that can give us a lot of different issues. Our short-term devices are run anticoagulated, as you can imagine. Sometimes, though, we can't prevent bad things from happening. This is actually a patient of Dr. Marr's and I from a previous institution who had an ischemic event, neurologic event that converted hemorrhagically. And she actually got coiled and was somewhat neurologically intact, which was we were very, very happy about. But the point that I'm trying to make is there's a lot of different things that can go wrong with the devices, and there's things that we have to be careful of, like RV failure and clotting, those types of things. So we have a lot of good protocols to use for our short-term devices and for our durable devices that people are really comfortable using, and we put those in place just to protect from hemolysis and clotting and things like that. So this is a good slide to talk about more durable devices and their outcomes. They studied quite a few patients. Most recently, the top line under implant dates is from 2008 to 2010. There was about 1,500 patients. And at 6 months, there was 89% survival. And at 12 months, there was 85% survival. And if you let your eyes go all the way down to the bottom line, back in 05 and 06, which really was not that long ago, the survival at 12 months was only 68%. So what this shows is over time, our technology is greatly improved. We're learning how to take care of these patients better. We're still learning. There's things that we do here. We're in many, many trials with our MCS patients, trying to figure out how best to take care of the patient population and how to manage a device in a patient as well. But survival rates are much improved, and actually here at UW they're even higher than 85%. So getting a little touchy-feely for a moment. So our advanced heart failure decision making is not taken lightly. We have a huge multidisciplinary team taking care of this patient population. We meet weekly to talk about all of our patients we're considering for transplant, and that's on Thursday mornings. And then we meet on Thursday afternoons at 4 o'clock to talk about all of our ongoing VAD patients. You guys are always welcome to come to these meetings. We have, again, multidisciplinary teams, so social workers, pharmacists, surgeons, etc., coming to make sure that we're making the best decision for our patients, taking into consideration what they want, what their family wants, and what's ultimately going to be the best decision for them. So just know that we go to great lengths to make sure that's done, and you guys are a part of that team now, so we would love to have you participate. If you have a patient that we're considering for any of these, or if you have any concerns, you can always talk to one of us about. So again, that's my plug, that we're a team, a big happy family team, and we're here to help you. MCS Consult team is here to just help, and you can always ask us questions, pull us aside, ask for articles. We have a lot of geeky things like articles flying out of our pockets about things, so we want to make sure you utilize us, and just feel free to always ask us questions. So, any questions? Anything I need to add, Dr. Marr?
Are you guys clear on the issue of stage functional class INTERMACS profile. So in order to completely characterize an advanced heart failure patient, you would have to include all of those. So it would be most likely stage D, functional class 3B, 4. The simplest way to define functional class 3 is really, if they can't walk a block or a flight of stairs without symptoms, they're at least functional class 3. If they have any symptoms at rest, and the ones that are subtle but class 4 defining are orthopnea, so osteonomy, pillows to sleep on. P and D, you wake up in the middle of the night, short of breath, sit on the edge of the bed. When we see these patients in clinic, a lot of times what they'll relate is, oh, I have anxiety. Something's all the time. And a well-intended primary care physician will give them Xanax. It turns out when you start asking more granular questions that the anxiety is, I'm short of breath, I'm sweaty, I wake up, I have to sit on the edge of the bed, and it's not really going to get better at Xanax. It's a function of high filling pressures and low cardiac output. We are a large teaching institution, and so you're going to encounter a Groundhog Day phenomenon of trainees that start every July cycle. And over time, you guys are going to evolve into the content experts that are the constant fixtures of these services. And then the residency fellowship cycle repeats itself, like Groundhog Day. So you're going to see some learning curves associated with that, and we appreciate your patience in interacting with our trainees. And also, as the content experts, you likely have to adjudicate some documentation pieces. So you're gonna see occasionally residents writing notes on somebody who's in the ICU or CCU with a balloon pump, and they'll call somebody function class 2 because they ask them, are you short of breath right now? And they say no. There you go. So because of the issue of the clinical trials that Jennifer mentioned, and all of the data that we obtain is publicly reported. So we report to the ISHLT UNOS registries, we report to the INTERMACS registry, we report to Medicare, we report to the Joint Commission. Every clinical trial patient has an events committee associated with these documentation pieces, that the integrity of the data has to be accurate. So if there's any issues surrounding that, please feel free to reach out to us anytime. We can't, it's very problematic if a note says functional class 2 and INTERMACS profile 5, but they're laying there with a balloon pump or they're on the butamine or whatever. It creates all kinds of issues. So we're happy to address that anytime. And it's really a collaborative and partnership approach to care. So there's no such thing as a consult that's inappropriate or a question that's not germane to us. We're happy to support you guys to practice at the top of your scope. And again, you're joining an amazing team. And I think that you'll find that your colleagues are phenomenal. We're very excited about